Thank you. And thanks for everyone that's watching. So I think today is a particularly exciting webinar because we have some really great panelists. Dr. Ghassan El-Haddad is our both interventional radiologist and nuclear medicine doctor. So he does various liver-directed therapies as well as PRRT with Lutathera at Moffitt. Phil Boudreaux is really internationally known surgeon who I think operates almost exclusively or exclusively on neuroendocrine tumors in the last decade. Would that be accurate?
Um, Pretty close. That's probably 90% of what I do, 90, maybe 95.
Right. And really pushes the envelope, I think, further than any other surgeon in the world as far as what can be done for neuroendocrine tumors surgically. And lastly, Ashley Christman, who's, as you can tell, in the U.S. military. I forget which branch, Marines or?
Yep, Marine Corps. That's right.
Yeah. And came from San Diego to see us about getting treated with Lutathera, and but we sent her to Dr. Boudreaux for debulking surgery, and thankfully she's come out looking fantastic and competing in sports, and yeah. So I guess the goal of today's meeting is to talk a little bit about how we push the envelope in terms of what can be done in particularly difficult, challenging cases. And Phil, maybe I can start with you. For most cancers, surgery is done only if it can be curative, meaning if it hasn't spread, or even if it's spread, or if it's spread to a few spots that can all be removed surgically. But with neuroendocrine tumors, we tend to go beyond that. We operate in many cases where patients can't be cured, but with the goal of either palliating symptoms or removing as much disease as possible to improve long-term prognosis. So maybe you can talk a little bit about the concept of debulking surgery. What does that mean exactly?
Well, so when we talk about different types of cancer surgery, we look at cancer surgery with curative intent, means you're trying to remove every last microscopic bit of disease and one and done, which is very rarely the case, except in a few exceptions. We can accomplish that with neuroendocrine tumors because they're typically metastatic at the time of presentation, and sometimes there's stuff too small to see at that point in time that maybe it's going to show up later. So most of the surgery we do is to try and, again, correct symptoms if there's things like obstructions, or if there's a tumor pressing on something that's hurting or causing a blockage of some kind, and that sort of thing, as well as the tumors that are functional that produce some type of syndrome, whatever hormone or evil humor they produce, to try and decrease the evil humor factory so they produce less hormone of whatever kind it is, to improve symptoms in that regard. But one of the things we do know, the final common pathway for a lot of these tumors, whether they start in the lung or the pancreas or the intestine or a few other places, the final common denominator seems like they always like to go to the liver. And so for many patients, the life-limiting problem is when the liver gets overburdened with tumor and they can't function properly anymore, then that's pretty much what causes the person to depart this earth. And so the idea is if you can do something to help the liver, you can not only improve the quality of life, but you could probably extend life. And what we've learned over the years is that you don't have to get it all out. You just got to get most of it out, or the worst of it out. And then we rely on our non-surgical colleagues to take care of what's left. Sort of the Marines come in and do the mop up. And so, to use a pun, but it really is true. I mean, there is no one modality that takes care of patients that have this problem. It is definitely a multimodal, multidisciplinary approach to have the best outcomes. And we have patients that we saw that were on hospice with stage 4 disease 20 years ago and are still alive today. And they got rid of their hospice and they went back to work and worked long enough to be able to retire like everybody else. So it's really a remarkable disease. You have the advantage of it. The majority of these tumors are slow growing. So you have the luxury of time to plan your therapy, plan your approach, plan your next move. Whatever we do for patients, we always want to have the next move in mind, so that whatever we do up front doesn't take them out of the path to get one of these other modalities down the road. So you really want your care, I think, to be delivered by someone that knows about all these different modalities and which ones to sequence, and where does surgery come in, where does PRRT come in, where does liver-directed embolic therapy come in, where do clinical trials come in, all the sort of other systemic therapies that we can maybe offer with chemotherapeutic agents and so on and so forth. I think that's been the key to long-term success. And while we do have patients that are like 20-year survivors now, they still have disease, but it's in the background. It's not putting them in the hospital. It's not hurting them from participating in their activities of daily living and so forth like that. So that's kind of our goal. Whenever we approach someone, can we improve their quality of life? Can we extend their quantity of life? And is an operation the right thing right now, or do we need to do something else first?
So just to play devil's advocate, let's say the patient is not particularly symptomatic, and the goal is to improve long-term prognosis. Yet we obviously have no randomized studies of surgery like we do with medical therapies. No one's ever done a study where they say, randomized patients half get surgery, half get something else. So we're really relying on intuition to tell us that it improves prognosis, right? I mean, when you think about it, patients who are candidates for surgery are also generally healthier than patients who aren't. They tend to have fewer tumors, less aggressive disease.
Right.
But it seems like there are cases where, even without good evidence, almost anyone would agree that surgery is the appropriate thing. For example, if there's a few large tumors that you can remove without removing too much normal liver tissue, that's clear cut. But I saw a patient yesterday who had about 30, 40 tumors in the liver, small ones, relatively young, relatively low grade, but not particularly symptomatic. What would you do with a case like that? Would you recommend surgery, or would you go with medical therapy?
Well,
or both?
Like I say, I don't think they're mutually exclusive.
Yeah.
I think we need to get away from that idea. I think they're complementary.
Right.
So the problem with surgery is it's like real estate: location, location, location. Where are the tumors that are most likely going to cause a problem? Are they hilar and they're going to eventually obstruct the bile duct and the portal vein? Because then you have a whole new set of problems. Are they going to obstruct the hepatic veins? And you have what's called a Budd Chiari. The liver can't get the blood out. It can get in, but it can't get out because the veins are blocked. So you have to look at what, if you know the natural history of this disease, and if you wait long enough, they grow. We have ways to slow them down, but we don't have a way as of yet to stop them growing completely. So then you say, well, in X number of years, we know this tumor is going to obstruct this, that, or the other thing, whether it's bowel or a bile duct or a portal vein or some other critical structure, a vena cava, something. Are they going to be any healthier 5 years from now than they are right now?
Right.
So that kind of goes into the equation. Are they in the best possible shape medically to withstand, and nutritionally to withstand the rigors of an operation? If you can mitigate against these horrific complications rather than waiting for them to occur and then trying to drag somebody up out of a deep hole, it certainly makes my life a lot less complicated when I know the natural history of a tumor in the small bowel is going to lead to obstruction sooner or later if you wait long enough. It's all they know how to do is obstruct or bleed or perforate. So one of those bad things is going to happen if you wait long enough. Why? If you have a campfire, do you want to wait till it's a forest fire if all I have is one bucket of water?
Right.
Douse
So what techniques do you use generally to remove tumors that are deep in the liver? Do you tend to enucleate them or use a microwave ablation, or how do you
well, if they're really deep in the liver, we'll ablate them. We don't want to go through a lot of normal liver to get to a solitary deep tumor. If we can ablate it, safely and approach it with a microwave needle, which is like basically it's a microwave antenna. It's a long needle. You just stick it down in there and turn on the juice, and it cooks the tumor like you cook an egg. So if they're within a few centimeters, or I would say, I don't know, less than 5 or 10 centimeters from the surface of the liver, and a lot of times we'll just try and open the liver and get them out, and enucleate them and then close the liver back. Again, it's about location. Where are they in relation to critical structures within the liver, portal veins and bile ducts and so forth?
So let's switch gear and talk about mesenteric masses. That's usually the first place where small bowel neuroendocrine tumors spread. They're often desmoplastic, meaning they kind of develop this fibrous tissue that tethers surrounding bowel. They like to attach to blood vessels. What does it generally look like when you operate and get inside and see these things in the operating room?
Well, so when we have this, what they call desmoplastic reaction, it's a lot of dense, hard scar tissue. What we know about that stuff in most cases, that it encases, but it doesn't invade. So if you can find the plane of separation between the blood vessels and all of this material, whether it's scar tissue or tumor, and sometimes you can't tell which is which, it kind of all looks and feels about the same. And it's very dense stuff, so you have to peel it off of, especially peeling it off of the veins very carefully, or the next thing you know, you're looking at the inside of the vein or the artery, and you kind of want to avoid that when you can. But it's a very time-consuming aspect of the cytoreduction when people have mesenteric encasement. But the problem is when that stuff wraps around the blood vessels to the intestines, a lot of times patients are symptomatic. Every time they eat, they get basically intestinal angina. They get a lot of pain and a lot of GI tract symptoms because there's not enough blood getting down to the gut to help them digest their food. And so instead of getting chest pain from angina with not enough blood to your heart, they get gut pain. And so the idea is to try and improve that and improve the blood flow to the circulation to the intestines, as well as prevent the eventual complete obstruction of that vessel, which will then lead to intestinal gangrene. And then they become an intestinal cripple, have to have most of their intestines removed and live on intravenous nutrition for the rest of their days, which is another thing you try and prevent from happening if you can.
Yeah. Now, most surgeons, when they operate on mesenteric tumors, they will only do it if they can remove it in its entirety, right, with surrounding tissue. And that can be challenging because the closer it is to the center of the abdomen, what we call the mesenteric root, the more bowel you have to resect as part of the surgery, right? And eventually that could lead to short bowel syndrome.
It could, but what we try and do is remove as much of that tumor as we can and basically skeletonize those blood vessels without taking the blood vessels with the tumor. And so we will try and minimize the amount of bowel we have to resect by doing that. And then eventually you get to a point where you've protected the main blood supply to most of the intestines, and there may be just one small area now you have to resect that also is the watershed or the blood supply to the bowel you knew you're going to have to resect anyway because it's got a bunch of tumors in it. So
there's not a lot of surgeons that do that.
We don't resect any bowel until we've finished cleaning it all out and we see what looks good and what doesn't look good.
Yeah, I was saying there's not a lot of surgeons that do that.
Well,
are there
I wish there were more surgeons
that
did that. I wish there were more surgeons that did that because I'm not getting any younger.
But yeah, it's an interesting approach, and we've seen some cases good outcomes from that. Patients who were quite symptomatic, who have come back and felt a lot better. And lastly, I wanted to just talk about peritoneal disease. What's the difference? Talk to us about the difference between mesenteric and peritoneal disease.
So when we're talking about the mesentery, this membrane that connects all the bowels living on this membrane, and in that membrane lives the blood supply. If you think of a Chinese fan all folded up, the bowels are kind of all folded up, and that membrane sort of bends and waves back and forth on itself. It's kind of all collapsed. You have to sort of fan it out and then work on plucking all these tumors off of it. So that's the mesentery piece. When we talk about a thing called carcinomatosis or peritoneal implants or peritoneal metastases or disease. We're basically looking at somebody who took a bucket of BBs and threw them in the abdomen, they went everywhere. And so they can be as small as BBs or as big as, golf balls, but they're scattered about, and they can also cause a really intense desmoplastic reaction, what we call in scarring and hardening, and basically the abdomen sort of gets frozen and nothing can move. So the bowels can't slip and slide and move around like they're supposed to be able to move stuff along, to be able to digest your food. And then that's a real big problem once that happens, is it's really hard to fix. So we try and clean as much of that stuff out as we can. We used to have to basically strip out the whole lining of the abdomen and take all that stuff with it, the lining off the mesentery, the lining off the abdominal wall cavity, and the lining, of everything. That's a super time consuming process. We now have a new toy called a plasma jet. It's an argon beam, very precise little, it looks like a little laser when you see it in action, but it basically, you can program it and set the settings on things in such a way that it vaporizes these little tumors. And so the way I tell people to learn how to use this device is to practice taking the skin off a cucumber without burning the cucumber underneath. That's what you do. And so once you go through a bunch of cucumbers and you feel confident that you can handle it, because as long as you hold it on whatever you're holding on, it'll keep burning all the way through to the floor, So you got to be very careful how you use it and when you use it. But we found that to be a very handy tool, because it's a lot faster than peeling all this stuff out one at a time when there's like 1,000 of them in there.
Well, what if there are 1,000? I mean, what's your limit? How many? Do you ever go inside and say, okay, this is too much?
Rarely, unless there's some hemodynamic instability or the anesthesiologist says time to quit.
All right.
Because you have to, it's like I say, it's not a one-man show. The whole team has to be comfortable with what's happening. The patient has to be hemodynamically stable. We're not having excessive bleeding problems or blood pressure issues or respiratory problems or stuff. So assuming that's the case, I mean, sometimes these operations take a long time. You got to be willing to spend, 4, 5, 6, 7, 8, 10 hours sometimes in the operating room. And then not a lot of people are just willing to do that.
So, Ghassan, maybe you can tell us a little bit about what we found when it comes to PRRT, specifically Lutathera, and patients both with peritoneal carcinomatosis and mesenteric root tumors. And for those who don't know, maybe just a few sentences about what PRRT refers to.
Yeah. So PRRT is systemic radiotherapy, is peptide receptor radionuclide therapy. It's a new therapy that, I mean, it's not really new, but it's newly approved in the United States a few years ago, where the treatment is very personalized. So we do a scan initially. It would be a PET scan usually, or a SPECT scan, to see if the tumors, the neuroendocrine tumors, have the somatostatin receptors needed for the therapy. Usually neuroendocrine tumors have a lot of somatostatin receptors. So we will do a scan, and if the tumors have a lot of these receptors, they would look, the radioactivity in those spots will be high. So there will be high SUV, if you want, on the PET scan. And the hotter the tumors are, the better it is for these therapies. So it's a very targeted treatments. We do the PET scan or the SPECT scan, and if the patient is a candidate, then we inject the radioactive material that circulates in the body and then finds those receptors and attaches to them. Then the radioactivity is absorbed inside the nucleus of the cell, and the radiation, when it's close to the DNA, to the nucleus, it can cause DNA breaks and cell death of the tumor cells. So that's PRRT. It's given into multiple cycles because we cannot give very high doses of radiation in one setting. Since this is systemic, it circulates in the body, is excreted mainly by the kidneys. And in order to prevent the kidneys from getting too much radiation and radiation injury, we have to infuse an amino acid infusion. It's predominantly two types of amino acids, lysine and arginine, to prevent the kidneys from reabsorbing the radiation while the radiation is being excreted by the kidneys. So that's what makes this therapy, usually longer than other types of just a quick infusion. Takes about 4 hours, 30 minutes of injection of amino acids. Then the patient gets the radioactivity, and depending on how it's injected, it takes between few minutes to half an hour. And then after that, patients continue the infusion of amino acids. So that's the whole thing is the therapy. It's given into 4 cycles, usually every 2 months. We give one infusion. And if patients respond pretty well for at least a year from their treatment, we could potentially give 2 more doses in the future. Nowadays, we have new tools that we can study more about dosimetry to see how much the normal organs received, mainly the kidneys and the bone marrow. And potentially in the future, we may be able to give even more than 2 doses once we know exactly how much the normal organs received. Now, when we participated in the NETTL-1 trial and all the data before that in Europe, we have not had any cases, or there was no reported cases of patients having side effects from the PRRT in terms of peritoneal disease or mesenteric disease, specifically in terms of bowel obstruction. So once we started using PRRT in clinical practice, we've had a couple of cases, not too many. I think over maybe 160. When we reviewed the data, we have about 160 patients. Half of them had either mesenteric or peritoneal disease. And I think it was maybe 5 or 6 patients only had, major complication from the PRRT in terms of bowel obstruction. And that was somewhat surprising, to be honest, because of all the thousands of patients that were treated in Europe, we were expecting to hear about something that important. And we had to go back and review each patient who had mesenteric or peritoneal disease and whether they had an obstruction or not, and focus on the patient who had an obstruction to try to decipher what are the main risk factors if you have peritoneal disease or mesenteric disease, and making you at a higher risk of developing bowel obstruction after PRRT. So we had to go back and then search. And the criteria that we have started establishing is still evolving. I would say more recently, at least a year ago or almost 2 years ago, we added to that the involvement of the vasculature. As you mentioned before, the visceral arteries, whether either superior mesenteric artery encasement or even the venous encasement, because we had 1 or 2 cases that had problems with that following PRRT. So we have now what we call certain guidelines and criteria. Patients who are referred for PRRT will review their images. Every patient will have to review their images in details. And if we feel that there may be higher risk for PRRT, either we recommend treating patients with steroids. The role of the steroids is to decrease the inflammation that can come from the PRRT, because the idea is that if the PRRT goes to those spots and causes inflammation, the bowel goes into a state of shock. Or if it goes to the root of the mesentery where the vessels are crossing and the inflammation happens, it can crush those vessels and either limit the blood flow from going to the bowel or limit the blood flow from returning to the bowel, which can equally be bad. And in certain cases, it's rare, but if you have extreme situations, that can cause to very severe side effect, even death. So it is not something to be taken lightly. We give patients steroids if we feel that they need to, and in certain cases, we refer the patients for surgeons. Dr. Boudreaux has been one of our main referring patients where we refer to try to debulk and maybe remove some of these mesenteric lesions or peritoneal lesions in order to make the PRRT safer.
Thank you. That was a great summary, and that would be a good transition, I think, to Ashley to talk a little bit about her journey and how she ended up coming to see us and Dr. Boudreaux.
Yeah, absolutely. I am, again, my name is Ashley Christman, and I have small bowel stage 4 grade 2 NET diagnosed in 2021. However, when we found out in 2021 of the diagnosis, it was already stage 4, pretty far advanced, and started systemic therapy with monthly somatostatin analogs. And did that for about a year. I had a misread on a scan and about 6 months into my diagnosis from an oncologist who was not a NET specialist and didn't quite, I think, understand, I think much of neuroendocrine cancer, and just hadn't seen a lot of patients with neuroendocrine cancer. And we believed that it was stabilized at the time from that scan. About a year into my diagnosis, found out that was not the case. It had continued to spread. Did a diagnostic laparoscopy, found out that I had peritoneal carcinomatosis, and it was one of the most advanced cases with the National Institute of Health at Gene, and then started to explore options for various trials. I found the clinical trial that Moffitt was offering with PRRT alpha therapy, and was really interested in that. I actually, interestingly enough, had initially been, once we found out the cancer had spread again, it started to spread to bone, which is why I started looking at next steps for treatment options. I had been referred over to go ahead and start PRRT with lutetium-177, FDA approved, kind of standard of care. The next treatment option that oftentimes is used when moving from somatostatin analogs to the next thing, and still had not really involved a NET specialist in my care yet, because I just didn't really understand the difference or the value of that yet at that time. And by just a twist of fate, the lutetium-177 had been pulled from the shelves globally at the time for a few weeks or a month or two due to a quality control issue in the plant. So I started looking into clinical trials and found the alpha trials. I got on the list in a couple different locations and fought hard to get into the trial. I looked at the research and thought it might be a better option for me. Waited for 6 or 7 months to finally get a spot, and went down to Moffitt, and as a dosing came up and it was available for me, and got my final screening. And at that time, Dr. Strosberg and Dr. El-Haddad sat down together and looked at my history, looked at all of the details in my scans, and really procured an individualized treatment approach for me, and identified at that time, once they did a really individualized assessment to induct me into the trial, they identified that I was not actually, it was probably not the best option for me due to the 2 high-risk factors of both peritoneal carcinomatosis and the mesenteric disease, and that it was pretty high burden from those factors. I had already at that point in my care talked to about a dozen surgeons in about 8 different states. I had been shot down for surgery, including some pretty aggressive surgeons in many locations, and some that were NET specialists. and had kind of written off surgery as an option for me. And at this point, I was told PRRT with lutetium-177 was likely not a safe bet for my particular situation, and also that the alpha therapy, couldn't be promised there would be any different results than with lutetium-177. So went ahead and was referred by Dr. Strosberg to go to New Orleans in my tour de cancer of the United States. Go to New Orleans from California after visiting Florida to meet with Dr. Boudreaux and look at surgery with Dr. Boudreaux. Dr. Boudreaux took me on, reviewed my case in detail. We had some pretty in-depth conversations about, what he saw and what he got from his scans and the conversations with Moffitt and with Dr. Strosberg. And, we talked about what we needed to do for surgery. For a lot of patients, a lot of my counterparts, I know that surgery tends to be one of the first options. It really depends on where you're at and the progress of your disease. For me, it ended up being my last and only option really that was left on the table because cytostatic or cytotoxic chemotherapy wasn't really an option for me due to, at the time, us believing that it was grade 1 and a lot slower growing. Probably wasn't really going to get much of a response from it. I was kind of considered to be too high risk for PRRT and at high risk of obstruction or inflammatory response. And so we really needed to look at doing surgery and doing so quickly at that point. And in March of 22, I went in with Dr. Boudreaux and his team, because I know he had some help in there with him for, I think, an 8-hour-long surgery where they did 12 procedures simultaneously, removed upwards of 1,000 tumors from the size of sand granules to the size of baseballs, and really, actually returned options onto the table for me for future treatment, in addition to significantly reducing the burden of my disease and giving me a fighting chance at life and longevity. I think we learned from that surgery that I had cancer in more locations than what we could truly appreciate in the scans, and also that I probably was within months of a full blockage or some other serious escalation.
So tell me a little bit about the recovery from the surgery. I know it was obviously a long surgery.
Yeah, the surgery, the recovery itself, I kind of learned throughout my disease progress that I really needed to listen to my body in the context of listening to my providers as well, and hear what my body had to tell me. And so I worked really hard physically, and I encourage counterparts as well to work hard physically before a surgery. So whether that looks like exercise for you, all you can do is walk, start walking. Walk 3 days a week, then 4 days a week, then 5 days a week for as long as you can tolerate, and keep kind of slowly, incrementally increasing that duration. Or if it means that you're already on the other end of the scale and you are, very athletic, then, make sure that you're doing a combination of hitting the weights and hitting the cardio and doing what right looks like for you to be in your peak physical fitness. But there are many things in life that we have to prepare for, and surgery is one of them that I strongly believe you should not go into passively. So I trained for surgery. After surgery, because I trained for surgery, I had to start just like everybody else with walking a loop or two around the nurse's desk while still in the hospital, and working my way up over the next several months. And I abided by the restrictions of my surgeon as any good patient, and did not lift over the 20 or 30 pound limitation for 6 weeks. But really, right after the 6 weeks was over, I was able to start picking up with weightlifting even again. And I started with walking a few weeks after the surgery outside for, half a mile, then a mile, then 2 miles. And, around the 5-week mark, started to jog and then started to run again, and was really able to get physical activity back. So the strength and the endurance returned, I think, fairly quickly, because also I helped my body be prepared for resilience. But, in addition to that, there are also challenges when you have anatomical changes for just digestion and dietary needs and processing. Dr. Boudreaux mentioned earlier, part of the benefit of these surgeries can be the reduction in symptoms. In particular for me, I also have carcinoid syndrome. And with the reduction of burden, it also reduced the severity of carcinoid syndrome that I had. It's really rare that I get carcinoid wheezing anymore. The degree of flushing that I was getting prior to surgery dropped significantly. I'll still get flushing on occasion, but it's different triggers than it used to be, and a different severity of flushing, and certainly way less frequently than it used to be. So there are a lot of benefits there, but it does take some time for your body to adapt to the anatomical changes, or just the stress of surgery. And I've found that working with a nutritionist, especially if you can find a net nutritionist, is very helpful to get through that.
In retrospect, do you think you were having some chronic abdominal pain before surgery? Did that change at all?
Yeah, absolutely. I was having abdominal pain daily before surgery. I was absolutely having what I now appreciate was liver pain. I was having probably gallbladder pain as well. And then because I had a high burden of disease in the pelvic region as well, I would get pain both from my primary tumor and in the small intestine near the terminal ileum, and I would also get pain across the pelvic region from a high burden in the ovaries and uterus, and that some burning pain, aching pain, and it was daily. Absolutely was daily. And it starts slowly and kind of slowly increases over the years, and I think I hadn't realized how much I was dealing with that until it was gone, because I just kind of acclimated to it over time. But now I might have a week where I might have some pain a few days a week, and then I might go for weeks or months with no pain at all. So it's a huge difference. And I would go for a jog before surgery and would get really bad just a few minutes into the jog, really bad pain and kind of cramping and burning just in my abdomen, and would just have to work through it to be able to continue to jog. Sometimes it would kind of subside on its own. Sometimes it would just get worse. But I can go for a jog now and not feel anything like that at all. So, I mean, there's definitely been a lot of improvements in the element of.
Yeah, the pain you were experiencing might have been what we call mesenteric angina, basically like people experience when they have heart disease. And when you jog, you're diverting blood from your intestines to your muscles, and potentially starving the intestines if the blood vessels are narrowed. Now, after recovery, you eventually went on to get Lutathera, correct? On a study.
So I did.
Yeah.
Yeah, absolutely. So I about 6 or 7 months later, we looked at the remainder of the cancer, because I think and ended up moving probably 70 to 80% was removed from the surgery, and there are just some locations like deep inside the liver, and a few other locations that just can't really be reached. And of course, bone metastasis can't be reached by the surgery, things like that. So we looked at other options and saw, we're able to evaluate that the cancer that was remaining was still progressing. And so I wanted to be pretty quick at getting after that while my burden was at the lowest point it had been in years. I was able to get inducted into a trial in the National Institutes of Health, which was actually recommended by Dr. Strosberg based off of genetic testing that I had done a year or so prior. And I had one mutation of unknown significance that he thought might respond well to this trial. So that was really helpful to be able to pull in, things we had learned in the past that were irrelevant. Really, there wasn't really anything out there at the time that matched the very few kind of environmental mutations that we had identified. And now here we are a year or so later, and there is something that might apply. So those results can be helpful to just kind of keep in mind if that applies to anyone out there. But I went over to a trial at the National Institutes of Health, which had a combined PARP inhibitor and PRRT with lutetium-177. And because the high risk factors of the peritoneal carcinomatosis and the mesenteric disease were significantly reduced, and Dr. El-Haddad and Dr. Strosberg looked at my scans again together post-surgery and said, yes, we think risk has been reduced and mitigated. Obviously, it doesn't eliminate risk, but it certainly brought the option back on the table for me. They both recommended that I was, a good candidate for that trial. National Institutes of Health agreed, and but also agreed at Dr. Strosberg's recommendation to put me on a steroid treatment with the trial to just make sure that I didn't have an inflammatory response if there were any remnant peritoneal carcinomatosis or mesenteric disease that was just kind of waiting in the curtains to become problematic. So we did that as well with the treatment. I was able to complete that course of treatment for 4 cycles of the PRT combined with the PARP inhibitor, and was able to achieve stabilization of disease from that trial. Still monitoring for that for I think about 2 years after the trial. We'll continue to monitor, but as it is now, the cancer is still stabilized, and just keeping an eye out for anything I can do to help that stay the case as long as possible.
And I have to say, you look great.
And
Athletic, healthy.
tell the folks what you just finished doing, Ashley.
Oh yes, and to that point as well, I've also tried very hard to stay physically active. I know some people think, oh well, that's not for me, I can't do that, I have carcinoid syndrome, and exercise is a trigger. That's right, exercise is a trigger. But there are things that you can do if you talk with your providers, whether it's short-acting octreotide shots or Zermello or what have you, to help reduce the serotonin flushing. I personally take the short-acting octreotide shot before I know I'm going to do physical activity that is much more rigorous, and that helps prevent flushing and issues for me. Exercise is important. And so I've stayed active, and I was selected to be a part of Team United States for the Invictus Games. So what Dr. Boudreaux is getting at is I just got back from competing in the Invictus Games with Team United States, and which was a phenomenal experience. And again, just opportunity for me to continue to keep thriving and pushing forward, because we have to keep building things into our lives to thrive through. Me personally, I say I don't want to be a cancer survivor. I want to be a cancer thriver. We don't have a cure yet, but I know that they're working hard on it. We got our best people on it, and I hope to thrive all the way to the finish line for that.
That's fantastic. Well, thank you for sharing that, and it's always great to see you. we don't have much more time left, and I did want to give people a chance to ask some questions. I see one. The question is, would you operate on a 75-year-old non-symptomatic patient with a sub-centimeter net, grade 1 in the tail of the pancreas? Phil, I'll let you take that.
Probably not.
All right. If Phil says no to surgery, then it's a definite no. Yeah, that's kind of the opposite end of the spectrum. It's not that it's too hard to operate, it's the fact that we're increasingly finding these tumors incidentally. If they're small, low grade, they'll almost never behave in a malignant fashion. And we're seeing what some people call overdiagnosis, meaning tumors that are not clinically relevant or clinically significant that are found by accident. And if these are things that people would live with normally and with very little risk of progression, and of course surgery, even under the best circumstances in the best of hands, always has risk. What would you say the risk is of removing the tail of the pancreas as far as major complications or death?
If the pancreas is normal, there's a 20% risk of leak from the pancreas and fistula. That's the main one. The risk of death these days, doing it robotically, probably less than 1%, but it's not zero.
Right.
One of the things about surgery is you have to know when not to operate. And so that sort of has been refined over the years. We used to think every time we found one of these, we had to take them out. Now we know that many times for these little small tumors in the pancreas, especially if they're not hormonally active and not causing symptoms. I mean, the small ones that you have to take out typically are things like insulinomas, because people fall down with low blood sugars and drive their car into a tree or oncoming traffic because their blood sugar went too low. Obviously, that would have to be that would have to go. But for these non-productive, non-functional, what we call silent tumors, in the pancreas especially, we tend to sort of watchful waiting and just keep an eye on things. If they start to grow, if they exhibit some aggressive behavior that's worrisome, then okay, then we'll have a different discussion.
What about the any follow-ups imaging needed, or if you discovered it incidentally, would you just forget about it, or?
No, we would do follow-up imaging routinely. We would do every 6 months for a while until we were sure that things were stable. And then we might maybe go to once a year. I mean, part of it, you have to ask the patient what is their cancer phobia, cancer anxiety, risk tolerance. Mm-hmm. And some people just really want to know everything about everything and are really worried about these things. And so you have to do some reassuring, you have to do some explaining, it's going to be okay. We don't need to look at this probably any more often than every 6 months in most cases, and things like that. But we don't think it's a set it and forget it. We do think it's probably worth watching because, again, we think we know about the biology of these things, and there are some papers that have come out that have said, if they're less than a certain size, you can watch them. But we don't know with 100% certainty that that's true. And is it less than 1 centimeter? Is less than 1.5 centimeters? Is less than 0.5 centimeters? Less than 2 centimeters? What's the magic number where you can say, okay, this one we can leave alone, and then this one needs to come out? So we're still kind of refining that, where that gray zone is between, leave them alone and go after them. Mm-hmm. We may have some new non-invasive methods to go after these tumors in the not too distant future when histotripsy gets approved for the pancreas.
Oof.
You're sold on histotripsy? Have you had any experience with that?
We've done about 40 cases.
And what's your experience been so far?
I've been very happy. We've taken some syndromic patients that we didn't think we wanted to take to the operating room, but we're able to decrease their hormone production so that their syndrome symptoms got better. We don't see as much of what's called the abscopal response like we see with this treatment for colon cancer. This treatment uses ultrasound completely non-invasively to melt tumors. The reported incidence of the abscopal response, where melting the tumor in the process of liquefying the tumor and just breaking up the proteins without heat, that's the key. There's no heat, so there's no denaturing or alteration of the proteins. those proteins get picked up by the immune system and they form their own vaccine against their remaining tumors. And we've seen the tumors shrink about 30% of the time. With neuroendocrine tumors, it's a little slightly different animal. We're probably seeing that happen more like 10% of the time. But still, the fact that it happens at all is kind of remarkable.
And
Well,
More to follow.
I just had one patient undergo histotrypsy and did not go well.
Again, you have to know it's about patient selection. And right now it's mostly approved for just the liver. The pancreas trials are ongoing and kidney trials are ongoing. So I think it's a new technology we need to learn more about. We also need to know, just like surgery, when surgery was, we need to know who not to operate on.
Right.
right. And the cases that you have done are for liver?
Yes.
Liver.
Yeah, it's only, in this country, it's only FDA approved for use in liver tumors. The trial that's ongoing in kidney is for kidney tumor primaries, not metastatic disease as part of the trial, but I suspect once it's FDA approved for kidney application, you'll be able to use it for metastatic disease in the kidney as well. And then the pancreas trial just opened in Spain, and we're going to be opening one in this country in the next few months.
Now, I have to point out that these trials are just for efficacy and safety, and included multiple different tumor types.
Correct. Correct. But it's now FDA approved and Medicare approved for any tumor in the liver of any tissue type.
Sounds good. We have a question from Adriana. It says, I'm currently undergoing Lutathera treatment. Is surgery still an option after PRRT? It really depends on what kind of surgery we're talking about and what was possible before PRRT versus after PRRT. But so it's hard to answer, I suppose, without knowing more specifics. What we can say is that operating on the mesentery and peritoneum can be more challenging after PRRT. Would that be accurate?
It can be more difficult because sometimes the scarring is more dense and just more adherent and just thicker and tougher, but they're not mutually exclusive. And again, you'd have to know more about what is the overall tumor burden, and like real estate, location. Where is it? What is it you're trying to accomplish with surgery? And can you accomplish that goal? Or is it even indicated at this moment in time? It may not be indicated now, but it might be indicated later. So it's a moving
target. And on the flip side, sometimes we actually give PRRT with the purpose of trying to shrink tumors for future surgery. That's primarily for pancreatic neuroendocrine tumors. So there have been studies in pancreatic nets where tumors are maybe borderline resectable, maybe there's large liver metastases. And in some cases, we can shrink things with PRRT and enable surgery to occur that potentially could not have occurred prior to that. So it can make either surgery either more easy or more difficult depending on the circumstances.
Right.
Any other questions?
That was a good question.
Yes. All right. Well, I want to thank all of you. It's really a pleasure to see you. And Ashley, I hope you continue to do well. Are the competitions over? Has the United States won, or is it still ongoing?
No, the Invictus Games is over. Team United States did bring back, I think, the highest in the medal count. But with Invictus Games, it's really more so about us all being there together and kind of competing through our recoveries from various wounds, illnesses, and injuries from combat or service environments and what have you. So it's pretty inspirational. But I plan to take a break from that for a while and just kind of look for other ways to be active and go from there.
Sounds great.
Well, congratulations, Ashley. We're real proud of you.
Thank you so much. I appreciate it.
And thank you for your service.
Be there. It's truly an honor to serve, and I wouldn't still be here doing this stuff if it weren't for the team on this call. So, thank all of you. I really, really appreciate you.
You're quite welcome, and thank you for your service.
Yes, absolutely. All right. Well, thank you, everyone. Good seeing you. Take care.
That's
All right, bye-bye. Thanks for inviting.